Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center and the Region 4 Public Health Training Center are pleased to present today's event, the COVID-19 Patchwork Pandemic and Mental Health. My name is Stephanie Tapscott, and I will moderate today's event. I would like to take a moment to describe the work of our two centers and then introduce today's speaker. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health practices by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit the Southeast MHTTC website to learn more about our center and upcoming events. The Region 4 Public Health Training Center is one of 10 public health training centers funded by HRSA to provide trainings and resources for the public health workforce. The collective group of centers is called the Public Health Learning Network. They work to improve the nation's public health system by strengthening the knowledge and skills of the current and future public health workforce. The Region 4 Public Health Training Center serves 8 southeastern states. Their central office is located at the Rollins School of Public Health at Emory University, in addition to 7 community-based training partners and 3 technical assistance providers. They provide public health workforce trainings and student field placements. Please visit the Region 4 Public Health Training Center's website for upcoming trainings, as well as archived recordings of past trainings. I am pleased to introduce today's speaker. Dr. Benjamin Druss is Professor and Rosalind Carter Chair in Mental Health and the Department of Health Policy and Management at the Rollins School of Public Health at Emory University. He is also the director of the Southeast Mental Health Technology Transfer Center. Dr. Druss is working to integrate mental health, physical health, and public health. His research has focused on understanding and improving access, quality, and outcomes of care for populations with serious mental illness and medical comorbidity. Dr. Druss serves as on the editorial boards of JAMA Psychiatry and the American Journal of Psychiatry. He was a member of the NIMH, National Advisory Mental Health Council, from 2014 to 2019. In 2018, he was awarded the American Public Health Association's Carl Taub Award for a lifetime contribution to the field of mental health. Again, welcome, Dr. Druss, and thank you for being here.
Thanks so much, Stephanie. It's wonderful to be here with everyone today. Let me just pull up my slides. So today I am looking forward to discussing with you the COVID-19 patchwork pandemic and mental health. In a minute, I'm going to tell you what I mean by that term, but I'm really looking forward to speaking with you, with all of you. I'm going to be talking about how to think about the pandemic's effect on mental health, and what it means for public health practitioners and also for mental health clinicians. So let's start. We have a couple of polls just so I can get to know who's out there today. Stephanie, if you could pull up the poll. So who is your primary employer? State public health agency, state mental health agency, community mental health provider, local public health agency, federal public health agency, federal mental health agency or other. Okay, so I'm not able to see the responses, but hopefully you guys are able to put them in. And the second poll is about what you do wherever you work. What is your primary job role? Is it epidemiology, surveillance, health education, clinical care, administration, research and evaluation, or something else? I'm going to see if I'm able to see that. Oh, great. Okay. So it looks like today we have a really nice mix of folks working in public health settings and mental health settings. That's just what we had hoped for. And also a nice mix of those of you who are working more at the community level, local level, and those working at the state level. We also have some others, and hopefully we'll get to learn about who those are. And then with regards to job role, again, a really nice mix between more kind of public health work, particularly health educators, and clinical care, as well as administration. So again, really, diverse and balanced group, and I'm really looking forward to speaking with you today. So, patchwork pandemic. This is a term by a writer for The Atlantic named Ed Young, who's a wonderful science writer, who described the COVID-19 pandemic as a patchwork pandemic. Different states have experienced the coronavirus pandemic in very different ways. These trends average into a national plateau, but each state's pattern is distinct. The patchwork pandemic exists because the US is a patchwork to its core. Now, Ed Young was talking about differences across states. Of course, those are important, but in fact, there are differences, even if you drill down farther, there's differences from county to county, even from block to block. And similarly, there's many other ways, of course, in which COVID-19 has not affected us in a uniform manner. There are a number of subgroups, racial ethnic groups, socioeconomic groups who have been differentially impacted by the pandemic. And what I'm going to be talking about today is what that means for mental health in particular. We are the Southeast Mental Health Technology Transfer Center, as well as the Southeast. We're partnering with the Southeast Public Health Training Center. And both of these are serving a series of 8 states in the Southeast who, as all of us living here know, have been hit particularly hard by the COVID pandemic. This is a recent heat map. And what you can see is really all of the Southeast states are still currently in the midst of the pandemic with many cases, hospitalizations, and deaths. And the reasons for the Southeast being vulnerable reflect many of the reasons that the Southeast has faced other kinds of challenges in the past. There is a high proportion of racial ethnic minorities, and health disparities are a major concern in the Southeast. At the same time, in terms of the actual pandemic, there have been less aggressive state policies to control the spread, later closings, earlier reopenings, and these all come against the backdrop of relatively weak health and public health infrastructure. So the Southeast is really, particularly facing a number of challenges both in terms of the pandemic and our resources available to tackle the pandemic. So what do we know in general about disasters and mental health? That is sort of needed to frame how we think about COVID-19 and mental health. There's a pretty good literature that disasters can be accompanied by increases in depression, anxiety, post-traumatic stress disorder, substance use disorder. At the same time, most people going through these disasters do okay. They don't go on to develop clinical disorders. And at the same time, disasters in general tend to affect some populations more than other ones. Risk factors for post-disaster mental illness include low socioeconomic status, minority, racial, ethnic group, lack of social support, and also how close people are to the particular disaster. So this is kind of what we knew going into COVID-19. But we have to keep in mind that there are some pieces that are different about COVID from most of the disasters that we're familiar with. First of all, it is widespread. No region in the US, really no region in the globe, has been unaffected by COVID. And whereas normally disasters, whether natural, like a hurricane, or man-made, like say a shooting, typically other areas are able to come in and help the affected areas. But here really, there has been widespread challenges with COVID-19. Of course, it's affected different regions, different times, but it is affecting the whole country and even the whole world. Second, because it's an infection, because it's a pandemic, it brings with it a need for physical distancing. This reduces opportunities for social support and also has made it hard for people when they need it to actually get health services and mental health services. And I'm going to be coming back to both of these as we go through the talk. And then finally, the pandemic has been accompanied by a severe economic recession, possibly something more like a depression. And that creates a whole host of secondary problems, particularly mental health problems. So we're going to be talking about that. So what do the data show? There aren't a ton of studies yet from the United States, but there are a few. And we're getting more data as we move forward. There were a couple of studies published in June documenting rising psychological distress in the United States, and these were using data from April. So one used a national internet panel and compared self-reported distress from April 2020 to another survey that had been done a couple of years ago, and found a very large increase in distress from about 4% to about 14%. Probably the most rigorous study that's been done to date is one using longitudinal data. So what that means is you actually have the same people measured pre-pandemic and post-pandemic, which gives even a better view of how much the pandemic has impacted psychological distress. This was a study from the UK, and it found clinically significant levels of mental distress within the same people rose from 19% in the previous years to 27%, again, for April of 2020. So both studies finding very large increases in distress. At the same time, as I'd alluded to, as we're going to be talking about, this distress has not been evenly distributed. There was a study that just came out in MMWR that was conducted by researchers from Australia, collaborating with CDC. And it found 2 to 4-fold increased rates of a number of mental health problems and behavioral health problems, including depression, anxiety symptoms, and substance use. But it also found that this distress, these problems were not distributed evenly across the population. Groups at risk included younger adults, racial ethnic minorities, essential workers, and unpaid adult caregivers. And these groups had worse mental health, worse outcomes across multiple different behavioral health measures, including measures of anxiety and depression, of substance use, and even of suicidal ideation. Again, coming back to the issues around the Southeast, this is from the same study, and if you look, the kind of beige bars are the rest of the country, and the red bars are the Southeast. And what you see is elevated rates of anxiety symptoms, of depression symptoms, of substance use, and of suicidal ideation. We in the Southeast are at risk really for a whole host of behavioral health consequences of COVID for many of the reasons that I'd alluded to before. So how do we look in the US compared to the rest of the world? This is from a survey that just came out a couple of weeks ago, conducted by the Commonwealth Fund. And it looked at the percentage of adults who reported experiencing stress, anxiety, or sadness that was difficult to cope with since the beginning of the COVID pandemic. And what you see is that numbers varied across countries, but that they were highest in the United States. At the same time, the US faces kind of the double problem of having some of the highest level of distress, but also the biggest problems in being able to access care. This slide looks at, among those who needed and wanted care, mental health care, were they able to get that care? And rates were highest in Australia and lowest in the US, closely followed by the United Kingdom. So again, US faced by high levels of distress, but also challenges in getting access to care. So now I'm going to talk about who might be at risk. So we've said that this is a patchwork pandemic. It's a patchwork pandemic, we think, for mental health. Who are some of the subgroups who we need to be thinking about in greater depth, and why might they be at risk? So I'm going to be next talking about some of these groups, individuals who actually get COVID, healthcare, public health workers, people who are laid off, who are unemployed, those who are socially isolated, racial and ethnic minorities, caregivers, and then we're going to talk a little about also populations with pre-existing mental disorders. So I'm going to go through these one by one. So people with COVID infections first. Well, acutely, COVID-19 actually can lead to a range of neurological symptoms, including psychiatric symptoms. These are probably either direct effects of COVID on the brain or the body's inflammatory response to COVID. Coupled with that is the psychological trauma associated with severe illness. So people who are hospitalized, at risk of dying, particularly people who've had ICU admissions, are at elevated risk for post-traumatic stress disorder, depression, and anxiety. We're becoming increasingly aware of a group of patients with COVID who are called long haulers, and the disease is informally called long COVID. And this can be accompanied by a range of symptoms, including fatigue and lack of energy, but also by anxiety symptoms, mood symptoms, cognitive symptoms, brain fog. So we really don't know, the COVID is a novel virus that's only existed for about 7 months. We don't know what all these effects are going to be long term, but certainly people with COVID, who've had COVID infections, need to be a population who are monitored. Okay, so healthcare and public health workers. So there have been a number of studies starting in China, but also now a number of studies in the United States that have found high rates of anxiety, depression, insomnia, and burnout in healthcare workers during the COVID-19 pandemic. So, this makes sense, as we talked about, people who are closer to a disaster tend to have more symptoms, more mental health sequelae. And in the case of COVID, healthcare workers are, maybe worried about getting exposed themselves to COVID. They may be worried about bringing it home to their families. They may be dealing with burnout and exhaustion of all of the work involved in caring for patients with COVID. At the same time, frontline mental health providers, like many, and public health workers, many of whom are here with us today, are likely also at risk. For many of the same reasons as healthcare providers are. Work schedules have changed. There is, job insecurity, financial worries, and stresses of trying to provide clinical care while managing home life. So while there's less work done about frontline mental health and public health workers than healthcare workers, it's likely that this group is at higher risk as well. So Stephanie, if you can pull up the next poll, this is asking what measures does your organization have in place to address staff mental health and social needs? We're really curious to hear about what's going on in the community, what best practices are, how responsive your organizations are being, mental health and public health organizations are being in terms of providing for frontline workers' needs. Okay, why don't we see how those numbers look? Right, okay, so that's interesting. And this will be a good segue into something that I'm going to talk about later in terms of where some of the gaps are. But it looks like, we're doing sort of well on some of the broader tips for self-care, which I think most employers are providing. Maybe for those who need clinical services, there is access to mental health care. But a lot fewer are doing a lot of the work in the middle, where I think a lot of the need is. And we're going to talk about that more in a few minutes. Okay. So as I mentioned, the COVID-19 pandemic has brought with it very high levels of unemployment. There is a literature that documents that unemployment is associated with increased mental health distress and substance use, as well as even suicide. There had been a review done about a decade ago that found unemployment tracking to rates of suicide by country. At the same time, again, in the United States, because we have an employer-based health insurance, job loss may result in loss of insurance and reduce access to mental health services. So you've got this real kind of double jeopardy that we keep talking about, where you have problems, increased problems, and populations who are that have less ability to get the problems taken care of. Social isolation, right? So we're all physically distanced for sure now, doing this work over Zoom, like much of our lives. But often physical distancing is associated with social distancing and social isolation. There is a body of work about quarantine, which shows that it can lead to anxiety and confusion and anger. We all know that solitary confinement, which is the most extreme version, is extremely kind of traumatic experience. But also is the broader problem of loneliness. Loneliness is a construct that there's a lot of interest around as an independent risk factor for adverse outcomes, including early mortality. And loneliness, like so many other problems with COVID, is not, will hit some populations worse than others, particularly in this case, people who are elderly, who may not have access to familiarity with video technologies, and those who are living alone prior to the pandemic, who don't have family members or roommates or friends in person around who they can interact with. So racial and ethnic subgroups, this is hugely important for COVID in general. People, African Americans, Hispanics have disproportionately high rates of COVID-19. There's a whole bunch of factors that are probably explain that upstream, including socioeconomic factors, jobs as essential workers, higher rates of chronic medical conditions, also limited access to care and discrimination. So really, COVID has exposed a lot of the gaps, the challenges, the schisms in society that existed before and brought them into much higher relief. And it's likely many of these factors explain what I described before, which are elevated rates of mental health symptoms in these populations. As we talked about, some of the studies that are starting to come out are documenting that this burden in terms of mental health symptoms from COVID is greater for racial and ethnic minority groups. So caregivers, so unpaid caregivers, including those caring for young children, are likely at elevated risk of mental health symptoms. And that makes sense. It's incredibly stressful trying to manage work, manage family responsibilities, homeschool young children, all at once. And so this group has been found in a couple of studies already to be at elevated risk for distress. And I should note that this burden is likely to disproportionately fall on working age women. What's important to keep in mind here is in terms of prognosis, in terms of physical health from COVID, risk of mortality and adverse course of illness seems to be greater in men. So a man who comes down with COVID is substantially more likely to die than a woman. That probably has to do with immune systems being less effective in men than in women. But in contrast, possibly due to more factors around role definition, what I was just talking about, the psychological effects may be greater in women than men. So, this disjunction is important to keep in mind as we move forward between the physical health effects of COVID and risks and the psychological effects by gender. Finally, I want to talk a little about pre-existing mental health disorders. So there is a literature that suggests with other disasters that people with pre-existing disorders, say anxiety or depression, may be at greater risk. But I want to encourage you to think in a more nuanced way about this issue. And in fact, it also may be that the shared challenges that are associated with the pandemic, as well as coping tools that may have been developed before the pandemic, could also foster resilience. And I think a great quote about this that kind of brought it home for me was from an article in the New York Times in May that was talking about people's response to the COVID-19 pandemic. And this was a quotation from someone with a long-standing anxiety disorder who said, "I've been sitting with therapists all of my life telling them that the world is on fire. Does anything I do matter? Now the world is really on fire, sort of, and I'm trying to teach myself to see both the good and the bad and to see how I can actually be of help." So there are aspects in which the pandemic can kind of rally people, give people a sense of purpose, and also call into play some coping skills that people may have developed prior to the pandemic. And then just to mention briefly also, serious mental illness. So this is the 5% of the population with serious mental illness, typically severe enough, schizophrenia, bipolar disorder, or severe major depression, that it results in disruptions in people's ability to hold jobs, their ability to have private insurance. These are likely to place this population, who typically are treated in the public mental health sector, safety net facilities like community mental health centers. This population is likely to be at elevated risk for both for catching COVID-19 and for poor prognosis among those who contract it. And particularly subgroups who are in institutionalized settings, state psychiatric hospitals, homeless shelters, nursing homes, are likely to be at uniquely elevated risk. And there's a literature that is beginning to come out documenting outbreaks in all of these settings. Certainly nursing homes have been among the very, very highest risk settings. So what about healthcare? There was, when the pandemic struck, many people just stopped getting healthcare. There was a big dip in services in April through early May, and services rebounded partly, but not fully. The lines here are referring to all health services, but if you look just at behavioral health services, there was initially a 30% decline with a rebound to about 17% below baseline. So what this means is people may be getting less care, even when you account for telehealth, which is the blue line, which includes both telehealth and in-person services. People may be getting less services. They may have disruptions in care. It also means that that mental health providers, like many primary care providers, are really facing fiscal challenges at this point. For mental health providers, particularly in safety net settings, the drop-off in the number of people who are receiving services, coupled with changing case mix, more uninsured patients, coupled with a third hit of state budget cuts to mental health departments, are raising real challenges for community mental health providers. Okay, so now I'm going to spend the remainder of the talk discussing what we can do about it. And by we, what I mean is public health practitioners and mental health practitioners, and how public health practitioners and mental health practitioners can work together to address some of the mental health consequences of the pandemic. So public health practitioners, and this includes people who are either on more of the data side of things or more of the health behavior change side, are and need to be conducting ongoing mental health surveillance, particularly looking not only overall at what the levels of distress are, but what they look like in some of these high-risk subgroups that we've been talking about. Mental health clinicians are typically going to be seeing people who develop a disorder that requires some kind of clinical care. Might require medications like antidepressants for people who develop severe depressive symptoms. It could mean psychotherapy. But typically these are going to be for groups of people who either self-identify or who are identified as actually having a clinical disorder. A lot of what we've been talking about today is in the middle between these two. It's in the middle between the sorts of interventions that can be done for at a large scale for general populations, and for those at the apex who actually get into the mental health system. Many of the people who I talked about earlier who had high levels of distress in April, that may not go on to become a clinical disorder. It also often is very well justified based on the enormous stressors that people are under. Every one of those high-risk subgroups that I talked about is going to be under a different, different type of stress, and many people fall into multiple of the groups at once. So what's really needed here is efforts, targeted efforts to provide support, provide sense of community, whether in the workplace, through other communities outside of the workplace, to address some of these underlying social factors that we've been talking about, and to, in terms of surveillance, to keep a close eye on the population to make sure that they're not moving into that top piece of the pyramid. So this is really where I believe that there is a great need, and a need that I hope that many of you who are with us today can begin to help us think through. The people who are distressed by the pandemic are in one or more of the risk groups, and to think about targeted ways of addressing the distress. The distress is really kind of a red flag for the fact that there are other problems that are going on. So I would love to hear now, I think what is a final poll, about your organization's highest priorities in addressing the mental health consequences of COVID-19. I believe you can answer 2 of these. So is it better data? Is it better relationships between mental health and public health? Is it kind of public awareness? Is it more financial resources, or is it more support for employee self-care? Okay, I'd love to see the results of that. Okay, so a lot of interest around public awareness. That's a really great. Yeah, I think there is a need. There's a need in the general public. There's a need for kind of cross knowledge and training between mental health and public health clinicians, but also, the second that I'm seeing here is support for employee self-care, which, as we've talked about, is really important. It's important for everyone, but particularly people who are on the front lines in addressing the pandemic, like many of the people here today. So I just want to throw out, in conclusion, a concept that I think is kind of a way of keeping some of this in mind. So in medicine, there's this concept of precision medicine. A lot of times we'll be having a treatment, or whether it's a medication or a psychosocial kind of treatment that is sort of developed as kind of a one-size-fits-all treatment. But really, there's a need to better tailor it to subgroups. So just as it's important in medicine, it's also important in public health and in public mental health. If there's one thing to keep in mind from, to take away from this talk, it's that if we have a patchwork pandemic of COVID infections, if we have a patchwork pandemic of mental health effects of COVID-19, then we are going to need to have targeted interventions for higher risk subgroups. And those needs are likely to vary across subgroups, and also to recognize the fact that many people will fall into multiple subgroups at once, multiple high-risk groups. So with that, before I jump into questions, which I'm very much looking forward to, I want to just say that our region over the last 5 months or so has been doing a lot of work in this area, both the Mental Health Technology Transfer Center and also the Public Health Training Center for Region 4. These include resources for supporting provider well-being during COVID and building resilience. We've had one webinar targeted towards public health practitioners. We've had at least a couple targeted towards mental health practitioners. We will be having more moving forward. And we've also been doing a lot around how to retool mental health systems for during the pandemic, and also for the new normal, whatever that looks like in the post-COVID world. So I would encourage you to go to the to our website. If you just if you don't have a link, just look up Southeast MHTTC, and we have a whole list of a series of webinars, of infographics, and other materials addressing these and other issues related to COVID and mental health. Okay, so I'm going to stop sharing my slides, and I want to open up for questions. So please feel free. I think probably in the Q&A feature. Let's see if we have any in chat.
Thank you so much, Dr. Druss. Yes, we have about 10 minutes for questions and answers. So if you want to type your question and submit it to the presenter, please use the Q&A feature, located at the bottom of the screen, or we'll also be fielding the chat box.
And also, while you're at it, I see questions starting to come. I would encourage you to put in, I guess, the Q&A, what you, what would be helpful for you? What more can we be doing in terms of our technical assistance activities within the region? What more, even for those outside of the region, would be helpful? Where do you see the need for resources? So I see a thank you. You're welcome. But encourage any others. Don't be shy. Okay. Here they come. So what are some resources that can be given to employees to help with resilience? That's great. We have some on our site. That might be a place to start. I would say that, so there's a lot of tips around, self-care that I think probably a lot of us know about, but it may be easier to know about than to actually do. And I think a lot of those around, keeping a work-life balance and kind of working virtually are all important. But of course, it's going to differ across different employee groups. It's going to depend upon people who are working in person versus who are working remotely. It's going to be different for people who are kind of on the front lines and potentially being exposed to COVID versus other employees who may be not as directly exposed. So I'd encourage you, so places that you could look, again, you could start with our website. You could look at CDC, which has an increasingly large and high quality number of resources, infographics. But feel free to contact us if there are particular kinds of things that you're looking for. Okay. So I see another question. What do you think is the most important aspect for mitigating the increase for mental health conditions due to COVID? Where should organizations be prioritizing their efforts? Wow. So I really think that, it's going to vary. It's going to vary based on some of these, the different groups. So I'd say, again, just for sort of, people in general, keeping an eye on like the actual real world challenges that employees are facing and asking them about what those challenges are. If you're a supervisor, kind of keeping in close contact with your supervisees. For people who are running community organizations, state agencies, using town halls, to get a sense for what your employees are currently dealing with to be able to address the challenges. And those can be very, many of the kind of social risk factors are things that may be the most important to address. Things like childcare, making sure that people have childcare, making sure that people's, are able to maintain, boundaries in terms of when they're working and when they're not working. But again, I think, that's probably, for many of us, there are things we can do for ourselves. There are things that we can do for people who are supervisees. And there are also things that we can do either for our clinical patients or the general population. And it'll just depend on where you're working. I'd say all the things that we've been talking about are areas where you can make a difference. Telehealth resources, right? So telehealth, I think, has been hugely important. It's been enormously valuable relative to if we didn't have that. There are many patients, as I talked about in that graph, who are now getting telehealth instead of in-person services. Teletherapy is huge, and it's likely that this will continue to be the case in the new normal. But, it's a whole new set of skills that we need to learn, whether it's working with patients, whether it's in supervision and meetings. We need to learn Zoom etiquette, or netiquette. We need to learn how to do telehealth really well so that it works as well or better as face-to-face services. Wow. So I'm seeing a lot of questions, and I'm just going to kind of go through them one by one, but I'll go through quickly. So if other people have them, I can answer. Are there programs that offer mobile mental health services for areas that have poor mental health services? Well, for sure, there have been services like assertive community treatment, even street medicine that kind of meet patients where they are. Of course, a lot of that, has changed in a physically distanced world. And that is why, telehealth has been so important. Telehealth, can improve access for populations who've traditionally been harder to reach, but can also bring a set of challenges. There's a digital divide and variable access that people have to telehealth that has to be kept in mind. So, really looking at, how to address areas with limited broadband service and other kinds of access barriers to telehealth services is more important now than ever. Will the replay be available? Yes, I think Stephanie can probably tell us about that in the end and how you'll be able to access it. Thank you for your interest. I hope that others who want to will be able to listen to it. Head Start program going virtual for 9 weeks. Best approach for identifying and reaching families with mental health needs. That's so important. However hard this is to do with adults, really doing it right with children, thinking about the balance of how, when you bring families in, allowing for privacy when needed, if you're talking to children or family members. These are all things that you need to be really intentional about. There are some articles that are starting to come out about how people have done this work successfully with children. But it's really challenging and important, in the same way that school remotely can be challenging with children. Do you see us anytime getting back to a somewhat normal workplace? Well, boy, I wish I had a crystal ball. My view, and maybe it's because I've been thinking about this, kind of in this stuff so much, is that, we will have a new normal that will probably be different from the old normal. Eventually people will be working, some more in person, but some of what's different now will likely remain. As I mentioned, on the clinical side, certainly telehealth, telemental health, teletherapy is likely to continue. But I think once, the genie is out of the bottle, as people, like to say in many ways, certainly, a lot more people will be doing more of their work remotely than before. Yes, one of the things that students want is what their teachers meet their own mental health needs prior to engaging students in the classroom. Touch points with supervisor are critical. Absolutely. Yeah, I mean, teachers, probably could also go in that high-risk subgroup. Many of them are facing a number of challenges. If they're doing work in person, they're worried about contracting the virus, bringing it home to families. If you're doing it remotely, they may be dealing with juggling, homeschooling for their children with schooling, for their teaching work. So it's such an important group, and one that I probably should have added and will add to future presentations. Reconnecting individuals who've lost connection with their community or social contacts during the pandemic. Or how to connect individuals who haven't really been connected. Yeah, so important. There are groups, either because they're just sort of late adopters of technology, maybe older patients, or older people, who just weren't up to speed, who may need training in how to do telehealth before, or training in Zoom, or training in FaceTime, or just in how to buy and use a smartphone. There's all these things that many of us may take for granted that people are gonna need. So I think we're almost out of time. I'm gonna take one more, and then I'm gonna let Stephanie kind of close us out. One of the things my organization has continued to think about is racism in public health. Even within mental health, ensuring our organization is training and encouraging providers to think about providing culturally humble care is key. Absolutely. Do you all offer trainings around this? Are the trainings around providing culturally humble mental health care? We are going to be doing work about this. So just to, as a little pitch for what we're going to be doing, some of the work we're going to be doing this semester. So we have a webinar next week that's going to be kind of a mashup of telehealth, but also culturally competent, informed care that you may be interested in. It should be the same time next week. That will be led by a very, very good speaker in that area that I think you would enjoy. But we're also doing work around culturally competent services and having conversations around structural racism and equity in peer services that will be coming up, both webinars and also more in-depth training, as well as a series that we're going to be doing with the National Hispanic and Latino Mental Health Technology Transfer Center, specifically around issues related to Hispanic and Latinx populations. So thank you for that opportunity to talk about some of the work we're going to be doing. Such an important question. And thank you all, really just great, diverse group of participants and great questions. Stephanie, feel free to help close us out.
Thank you so much, Dr. Druss, for your presentation and for answering our questions. The Southeast MHTTC and the Region 4 Public Health Training Center, thank you for your participation in today's event. We value your feedback and invite you to evaluate our event. We've posted 4 poll questions here in which they will provide feedback to the Region 4 Public Health Training Center about the impact of today's training on your work, knowledge, and skills. We also invite you to complete a SAMHSA required survey for the Southeast MHTTC. We've listed the link here on the screen. We would like you to take part in this survey as it assists us in planning future events. You will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. You will also have the opportunity to download a certificate of attendance for your records. Again, our centers appreciate your participation and feedback. This concludes today's presentation.